Hi again. So last time I talked about hypersomnolence, which means excessive daytime sleepiness. This time I'm going to talk about continuation of the same topic, but it's related to the condition called narcolepsy. Narcolepsy is not very common, but it's certainly talked more than the diagnosis has been established. But it is something to be talked about because that is one of the common things that happens. It happens in a younger age. The onset of narcolepsy is not going to be seen when you're 60, 70, 80, but it's seen at much earlier age. So excessive daytime sleepiness, which occurs in teens and 20s because of nightlife, because of the inadequate sleep, because of stimulants that people take, because of work that people do on computers and tablets and iPhones at night, certainly can cause insomnia, lack of sleep, which leads to excessive daytime sleepiness, as I mentioned in my previous video. But narcolepsy is pure related to excessive daytime sleepiness in spite of adequate sleep. Again, the sleep is disturbed a little bit in narcolepsy, but if you talk about excessive daytime sleepiness associated with certain other conditions, then that's called narcolepsy. There is a chemical or a hormone which is secreted from the brain called orexin or hypocretin. When people lack this, the narcolepsy occurs. And there are some examples where an autoimmune disease can cause such a problem, but more commonly it is related to just the lack of the cells or the cells being degenerated, leading to the narcolepsy. So in narcolepsy, we consider there are 4 conditions that can be seen. All 4 are not seen always. So the 100% of the patients have excessive daytime sleepiness, which is number 1. So when people are excessively sleepy in spite of adequate duration of the sleep or nighttime sleep, then we consider narcolepsy as one of the differential diagnoses. Idiopathic hypersomnolence or sleeping excessively during daytime in spite of adequate sleep at night for no obvious reason is called idiopathic hypersomnolence. So the narcolepsy number 1, 100% of the patient, is seen when people cannot control their sleep attacks, as they are called. So they may be falling asleep sometimes excessively, even with talking to someone, sleeping at traffic light, or falling asleep at traffic light, falling asleep when driving a longer distance with another person driving, or while reading a book, watching a TV, etc. The 6 questions that I told you last time, which calculates the score for excessive daytime sleepiness called Epworth score, is usually 18, 19, 20 in patients with narcolepsy. So they have uncontrollable sleep attacks, and that leads to the dysfunction or the problem with their usual job. There are other associated things. So there are tetrad. There are 4 things that can happen. The second one is called cataplexy. Cataplexy is loss of muscle tone, suddenly. So this usually happens during daytime. It happens with emotional excitement. Somebody tells jokes, somebody is upset, somebody is laughing. You suddenly lose the control of your skeletal muscles. Your knees might give way and you can fall. This is called cataplexy. Cataplexy is classically seen with narcolepsy. It is not seen with any other condition like idiopathic hypersomnolence. It is also not seen with excessive daytime sleepiness due to pure lack of sleep at night, say related to nightlife, insomnia, stimulant, etc. So in cataplexy, with an emotional excitement, people lose muscle control and they fall to the ground, or they can fall to the ground if they are standing. This is very classic. Unfortunately, the cataplexy is not seen in 100% of the patients, but it's probably seen in 70 to 80% of the patients. So cataplexy is the second thing that you need to be asking to see if it is there. The third is called sleep paralysis. Sleep paralysis is where people find this, and it is also seen in normal people. So one does not have to get excited because they have a sleep paralysis. It can happen when you are awake, but you cannot move any of your extremities. So this is called sleep paralysis. Some of us, all of us, might have experienced this once or another time in our life, where you wake up in the morning or in the middle of the night and find yourself unable to move. Your eyes can move, your breathing is okay because those two muscles are not involved, but your skeletal muscle, the muscles of your extremities, are involved, and you have inability to move them. External stimulus like somebody shaking you or waking you up will certainly bring that. This is seen normally, but it is seen excessively, or that is the third history that one can seek for when you are trying to diagnose cataplexy. The sleep paralysis occurs anywhere from 5 to 65% of the patients with narcolepsy. So the studies have shown that it occurs, but it doesn't occur in every patient. The fourth and the last one on the fourth, the tetrad, the four things that are common or associated with the narcolepsy is hallucinations. These hallucinations could be when you are falling asleep or when you are waking up, hypnagogic or hypnopompic as they are called. And these hallucinations occurs again associated with narcolepsy. So when you are about to fall asleep, you have these vivid dreams. Remember, normally dreams occur with REM sleep. So if you start, and the REM sleep occurs in the later half of the sleep. So if you're having these hallucinations when you are falling asleep, or you get this hallucination when you are waking up, then these are called hypnagogic and hypnopompic hallucinations. These are again commonly associated with narcolepsy. So four things. One is excessive daytime sleepiness, which is seen in almost 100% of the patient. The cataplexy, which is not seen in every patient, but can be seen up to 70-80% of the patient. The sleep paralysis, which is third, is seen in many patients, anywhere from 5 to 65% patients. And last but not the least is the hypnagogic, hypnopompic, falling asleep, waking up from sleep, hallucinations. So if these four things are seen, certainly a narcolepsy diagnosis can be suspected. If everything is there, you could do narcolepsy diagnosis clinically, though it needs to be confirmed. There are two things that I would talk about. I may have a time for this particular video or maybe next time. So the narcolepsy, as I said, occurs in younger people, and there are several other causes of daytime excessive sleepiness in younger people. So one has to be careful when suspecting, diagnosing narcolepsy. Narcolepsy or excessive daytime sleepiness can also occur because of use of drugs like narcotics, tranquilizers, etc. The stimulants and total lack of sleep also can have disturbed sleeps. So narcolepsy patient does have some disturbed sleep, does have hallucination while falling asleep, waking up. They have sleep paralysis, and they have excessive daytime sleepiness and a lack of muscle tone with emotional excitement like laughing or emotionally upset or something which causes you to be change your emotions. So these are the four things. The diagnosis is done by a formal sleep study. Every patient doesn't need it but must have it, according to me. So you need to do a sleep study followed by a test called MSLT. And I'll be talking about MSLT next time. But a sleep study where it shows that you have at least 6 hours of sleep, then this MSLT is done, which is called Multiple Sleep Latency Test, MSLT. The MSLT I'll talk about a little bit detail next time. But in MSLT is a test where you are allowed to fall asleep after a good night's sleep, and whether you go into a REM sleep or not will determine the cause of your excessive daytime sleepiness. I'll talk about it that next time. So MSLT and wakefulness test will be talked next time. Thank you for watching. If you like this, please subscribe. Tell it to your friends. Thank you. Have a nice day.